Hi, my name is Jennifer Donkin, and I'm a family nurse practitioner and a pediatric nurse practitioner at Children's Hospital Los Angeles. And I started my nursing career, my nurse practitioner career in 1987. This is when the AIDS crisis in the bleeding disorders community was first being acknowledged, and it was a time of heartache, a time of fear, a time of loss, but also, as I look back on my memories, it was also a time of the bleeding disorders community coming together, um, really uniting and being advocates for the fight against the AIDS pandemic. It was a time of tremendous growth for me personally in my career. The patients I will and families I will always be so grateful for because they let me into a glimpse of part of their lives, and they allowed me to care for them in very frightening, fragile healthcare decision making. Um, and from that, I learned so much about the bleeding disorder community. My recommendations for new nurses, wherever you are at in your career, that are starting out with um, joining us, is get involved, join your regional groups, um, seek out the nurses that have been there for a while and have expertise in the care of bleeding disorder community, and to really seek out other organizations, both nationally through the National Hemophilia Foundation, attend meetings, and also internationally through the World Hemophilia Federation. Once again, attend meetings and get involved. Um, I know that we are all here as a group to support and to continue education and to advance nursing practice.
I never thought I would be a hemophilia nurse. That wasn't anything that ever crossed my mind. I was an orthopedic nurse. I went to nursing school. My nurse manager that I really liked in nursing school was a PT, and she did orthopedics as well. And so when I graduated from nursing school, I went into orthopedics. I continued that. And when I moved to Colorado, I took a job on the orthopedic unit and was working there. And at that point in my career, I'd done orthopedics for 4 years and had never seen young people needing total joint replacement. And when I started on the orthopedic floor, I was meeting all of these young men who were basically the same age as I was, needing orthopedic surgeries, whether it was a total joint replacement or an ankle fusion or something like that. And it really piqued my interest as to why I was seeing these young guys needing this, really dramatic orthopedic surgery. Unlike most of my counterparts who got into hemophilia through either pediatrics or through hematology oncology, I was kind of like the lone rider out there that got in through orthopedics. It gave me an opportunity to meet a lot of these young adult men who needed the surgery and some of their families, and sometimes I would see them over and over again. I also worked with Dr. Weedle, who was the orthopedic surgeon who did the surgeries on our hemophilia patients. And I was in his clinic one day a week. So I did get to see some follow-up with these guys. Then when HIV obviously was a big part of the community, the nurse who preceded me, Brenda Risky, wanted to do some HIV research, and she suggested that I apply for the job. I did, and that was in 1987, and it was the best move I ever made with my nursing career. So I stayed at the University of Colorado Hemophilia and Thrombosis Center for 25 years. I retired in 2013 and have continued to do some stuff within the hemophilia community. But really, it was a very rewarding career move for me that I never would have anticipated when I got out of nursing school. I got a lot of satisfaction from this job in a lot of different areas. I think one of the biggest places I got satisfaction was really knowing I was making a difference in people's lives. Not just the patient, but their family as well. And we actually, as hemophilia nurses, and I know all of you who function in this role feel the same thing, you actually feel like you become part of the patient's family. And you're an extended family member, and you're somebody there that they can turn to in times of trouble, of stress, but you're also a person that they turn to in times of happiness. I can tell you I've attended funerals and I've attended weddings and baby showers and all kinds of things for patients in my bleeding disorder community. And that was all very rewarding. I really felt like I was making a difference. I think one of the other things that was very telling was actually the kind of difference you made in families. So it was just very rewarding when you knew you helped a patient or their family manage their bleeding disorder. For example, teaching a parent how to do infusions, giving them the freedom where they no longer had to go to the clinic or to the emergency room or rely on a home health nurse to come and infuse their child. We were able to give them autonomy and the ability to care for their child themselves. I think that was one of the things we really prided ourselves on, was making our patients independent. We didn't want them, even though they had a chronic illness, we didn't want them to be dependent on the Hemophilia Treatment Center. We wanted to make them as independent as possible so they could live their lives. You know, seeing a smile on a kid's face at camp the first time they poke themselves was certainly rewarding. I can't think of anything else that made me feel like I had made a difference in someone's life. Seeing that kid start their own IV and giving them the confidence that they could take care of their bleeding disorder themselves, that they didn't always need to rely on a doctor or a nurse to help them, equipping them with the skills where they could go forward and manage their disorder. I think another piece of satisfaction was seeing all the changes that have taken place during the time I've been involved in the hemophilia and bleeding disorder community. In 1987, when I started, we treated patients on demand for their bleeds. Our patients had crippling bleeding episodes. They spent a lot of time on the couch at home. It impacted their school. It impacted their work. Many of our patients spent a lot of time in the hospital with these bleeding episodes that were not controlled well on factor. Then in the early 90s, we started prophylaxis, and I'm happy to say that the treatment center I was at was instrumental in helping get prophylaxis started in the bleeding disorder community in the United States. And through that joint outcome study, we knew that providing prophylaxis for our young people, as well as our established patients, was a good thing, and it prevented that joint disease that initially took me into the hemophilia community. We went from treating the bleeds on demand to prophylaxis, and then we went from standard half-life factor products to our long-acting factor products. And today we have gene therapy. So there have been significant changes in the time I've been involved with the bleeding disorder community, and they've all been for the better. We manage HIV and hepatitis C now. When I entered the bleeding disorder community in 1987, many of our patients were dying from HIV, and we had yet to do our first liver transplant in a hepatitis C patient. That's all happened, and it's been extremely rewarding to see those changes and to know now that our patients have a way to treat some of these concomitant disorders that came along with that early treatment of their hemophilia. I think we know that there are going to be challenges ahead, and those of you who are still working in the field will have to deal with those challenges, just like those of us who retired had our own challenges. So you're going to pave the way for new and different things for your patients in the future, and I look forward to seeing where the future takes us all. Thanks.
So I was a pediatric nurse, and it's kind of a funny story. I'd always been interested in the Russian royal family and the English royal family, and was very fascinated by hemophilia. But I was a pediatric nurse who came in the hospital one day, and the nurse I was working with said to me, "I will take every other kid and every admission that comes in on this floor if you will take the two little boys in the back." And I was like, "What?" And she said, "Yeah, I'll take everybody if you'll take those two little boys in the back." And I said, "Well, what's with the two little boys in the back?" And she said, "Well, they have hemophilia." And I was like, "Oh, how bad can that be, right?" I mean, I didn't know a ton, but I knew a little bit about hemophilia. And I said, "Sure." And I walked back, and there were two little boys. One was 3 and the other was 4. They were brothers, and they were doing their immune tolerance therapy and literally swinging as hard as they could from the trapeze, which hangs above the bed. And then I went, "Oh," and they both had inhibitors, and they both had were hooked up to IV poles. And I was like, "Oh, okay, now I get it." So that was my introduction to hemophilia. And then after that, they had made a recommendation. They were looking for a nurse for the hemophilia treatment center, and they'd made a recommendation and from the asked families, and that family said, "Oh, you need to talk to this nurse," because she was really interested in hemophilia. So that's how I got into hemophilia care, and and then still in it. So I think the greatest challenges that I face as a nurse, I'm still facing today in the hemophilia community. We have always had a lack of staffing, and a lack of, we used to have a really big lack of funding, but we have a lack of staffing. We have a really hard time finding and keeping nurses, because this is we do a birth to death treatment center, so adults and pediatrics. And I think that scares a lot of people. Also, I think that it's hard because in Alaska, it's a very spread out group of patients. We have patients in Nome, we have patients in the Aleutians, we have patients in Bethel. And I think these places are not close together, they're not drivable, and they are most of them, only accessed by boat or by airplane. So that presents a big challenge for getting care. We've gotten really creative as far as we were doing Zoom visits and visits telehealth for a long time. And thankfully, the technology has gotten better. But I would say that staffing, finding someone to replace me and train as I'm getting closer to retirement age is really a big challenge. And it scares me sometimes because we have gone from a small clinic to a medium-sized clinic, and we're a standalone clinic. So we don't have deep pockets. And all of us do many, many jobs. So that, I think, is the biggest challenge to my hemophilia career. I also have been very blessed by being able to do something I love for 30 years with people that I love, and it's a wonderful community, and I'm very appreciative of that.
Well, I started as a clinic nurse, helping out with infusion classes, and then I transitioned into the HTC after finishing graduate school because the previous nurse practitioner was moving out to the West Coast, which was great timing for me. I love the idea of being able to meet the family with a newborn baby and then watch them grow in their understanding of the diagnosis and management, eventually becoming independent and advocating for themselves. But of course, this growth requires more than one person. And the bleeding disorder community provided so much support for me, my patients, and families. I became involved with the local chapter, serving on the board, networked with other nurses in my region to develop programming for retreats, worked with federal partners to develop a curriculum for experienced nurses. I then joined other boards to represent nursing as an integral part of the multidisciplinary team, and I was able to help plan meetings to ensure that there was content that would continue to develop the expertise of nurses in the HTCs. As a result of these experiences, I was able to share what I learned through presentations and publishing. And I couldn't have done any of it without the network of nurses who nurtured me and helped me to grow as a professional. There's the dog. What pearls of wisdom would you pass down to nurses just starting out in bleeding disorders? I would say to new nurses who are entering the bleeding disorder community, hello and welcome. You have joined an amazing network of providers, patients, and families who've been through so much and come together to improve lives. There's still so much to learn, so make sure that you're always curious, read the literature, sign up for continuing education, go to conferences, ask questions. Of course, listen to your patients and families, and lean on your nursing colleagues. Always remember what it was like to be the new nurse and become a mentor. Hematology in general, and hemostasis in particular, is both an art and a science. So be prepared to be a lifelong learner and enjoy the ride.
I graduated from nursing school in 1989. At that point, the HIV/AIDS crisis was well on its way, but there were still very few viable treatments for this. When I graduated, my heart was very much aligned with wanting to work with people with HIV. So I started working in the hospital on a unit that was taking care of AIDS patients. That was where I met my first person with hemophilia. I had been told that factor VIII, or any kind of factor, which was all human derived at that point, was teeming with hepatitis and HIV virus. I've since learned that in 1989 that wasn't the case, but that was the information I had. And so one of the first interactions I had with a person with hemophilia who also had HIV was trying to get factor. And I was gowned up, suited up. I had a mask on. It's all stuff we're very familiar with now with COVID, but that was not the case then. And I was trying to reconstitute factor. And it was kind of squirting everywhere. I had not been told any kind of technique to reconstitute other than it was, a volatile liquid that I was dealing with. And as I'm struggling with the technical details of this, I hear a little voice from the person lying in the bed saying, "I feel like a toxic waste dump." And I just thought, oh my God, how do I respond to this? And I realized right then what an incredible experience it was for anybody who was experiencing HIV/AIDS, but also particularly the hemophilia community. So I struggled, and I was able to give the factor, but I felt like I wasn't doing complete nursing care at that time because I couldn't address the emotional needs of this very sick man. I worked on that unit for a year and a half, and an opening came up at the Hemophilia Center, just part-time for a few months, and I thought, oh, this would be good. And then it became a full-time position. I haven't left. So I have been in hemophilia care since the fall of 1990. During those early years, we had 100 patients in our clinic that had HIV, and we still have 12 of them left, I think, around that. And early on, as I said, there were so few treatments that a lot of the opportunistic infections we were dealing with every day. And our role in the clinic was to take a call from a patient and then triage that with the ID for providers and with our hemophilic providers. And so it was very reactive nursing for a number of years. You'd get into work, straighten your desk, and someone would call, and you'd be dealing with some opportunistic infection, triage, hospitalization, et cetera, for the rest of the day. The other piece that was huge was there was a huge emotional component to this work, obviously. Many of our patients felt isolated. Many of ours came from small towns and weren't even, didn't even talk about their hemophilia, and certainly didn't talk about their HIV status with community members. Oftentimes, their spouses would struggle. And so the patients would not really talk a lot about their struggles because they didn't want to burden their wife further. And so oftentimes we became the sounding boards for every question and concern that they had. So we as nurses walked with them during this very arduous time. And over the years, we lost a lot of people and people that we've become very close to. And so that was a hard time as a nurse to provide the best care that you could and know that they would still die, and they maybe wouldn't die a very gentle death. But so rewarding, so heartfelt. And I got to know people's extended families. I attended funerals. I was part of people's lives in a very difficult but important, challenging chapter.
The first thing I would say is listen to your patients and ask them about their history, ask them their stories. You're going to learn a tremendous amount from your patients, more almost than you're going to learn from books. You'll also learn what living with a bleeding disorder has been like for living with a bleeding disorder has meant to them. The second thing I'd say is get to know the nurses in your region. You can learn a lot from them, and they're always a source of information and referrals. Get involved in NHF nursing activities. Third thing I'd say is go to summer camp. Not only is it a chance to get to know your patients, but you will see things like you'll experience the evolution of a bleeding episode from the time the kid falls down to the time they're treated, and really see how long it takes for that bleed to resolve. The fourth thing I'd say is work closely with other team members. Depend on them for their expertise, and they'll educate you. The fifth thing I'd say is get to know and listen to the other subspecialists that your patients see. You'll learn more about orthopedics, hepatitis, HIV, etc. from those patients. And last but not least, ask a million questions. I think that what provided the most satisfaction was getting to know the patients and having those ongoing relationships. When I started in my role, I was seeing both kids and adults. That meant that I got to know kids from the time of diagnosis, when they were quite young, until they grew up and became adults. I knew their parents, their siblings, and later their significant others. I was invited to weddings. I used to say to some of the adults, "I've known you since you were shorter than me." And at my retirement party, when patients took turns speaking, they talked about what their relationship, they talked much about they value their relationship with me, and episodes when my interventions made a huge difference in the outcomes of their care. It was a very rewarding career.
I'm the Von Willebrands outreach nurse, and I think one of the challenges being an outreach nurse is just patient contact with phone calls and house appointments, and never knowing where you're going to end up. And I do believe that most people are very thankful for the services that we give them in the community, but it can be a challenge to visit them sometimes in the places that they live and see some of the things that we can't do for them that they might need extra help with, and wish I could help them more. My role in the HTC has changed with fundings and with new medication, because the teaching that we used to do, we are not doing as much as with Hemlibra, the new medications. It's a kind of a one and done, so we don't get to see them quite as much and know some of the things that they may be in need of. So I would say the good thing is that less bleeds, they're more independent. The bad thing is that maybe we got to know them a bit more and help them a bit more when we were seeing them more.
What I see as the greatest contribution that nursing has been able to contribute is the fact that we're now starting to do research. So 10, 20 years ago, we didn't see much research in the community of hemophilia, but now we're looking at more qualitative aspects such as pain management, mental health, anxiety, PTSD, needle stick phobia. These are all important pieces that we can, as nurses, can contribute to the future of hemophilia and bleeding disorder care. My first exposure to hemophilia was back in my 20s when I was a bedside nurse. And I was looking, and that was back in 1985. I was caring for a young 18-year-old gentleman who had liver cancer and was dying of AIDS. So you can imagine what that care was like back then. When we fast forward 20 years later, I am now a nurse practitioner. My expertise was in geriatrics. That's where I was working. And this opportunity came up to work in the hemophilia space. I was looking for a change. And of course, when I interviewed, never in my wildest dreams did I think that I would get into that hemophilia area. But during the interview, I said, don't know anything about it, but willing to learn. And I was fortunate to have the most wonderful mentors, the physicians that I worked with that helped rise me up and make me have the ability to care for hemophilia patients independently as a nurse practitioner. It is also one of the most wonderful jobs I've ever had, with the camaraderie that the hemophilia space has given us. So nurses caring for other nurses. I could always call somebody if I had a question. I could put a question out on the listserv and I would get multiple answers from all over the country. And then, of course, the dynamic between the patient and the hemophilia treatment center in that integration of making decision-making. That was never done before. And that was pretty darn cool.
Hi, everyone. I'm Jen Maas. I'm a nurse practitioner in the state of Indiana, and I have been in the hemophilia community for 30 years. So I've definitely seen the impact of nursing and how things have changed. So to just preface, today I'm at camp and we've been here all week. And I think what a better way to highlight the impact of nursing on our patients' lives than thinking about hemophilia camp. So when I think about the nursing impact, I see that, you know, we bring kids to camp that maybe otherwise could not go, whether it's the social economics and their families can't afford it, or just because of their bleeding disorders, their needs, they are not eligible to go to a regular camp. So I really see the impact of nursing, and we have these kids outside of their comfort zone and no videos, no cell phones. And we really have the opportunity to get to know them as people without their parents around, see how they interact on a day-to-day basis. But more importantly is teaching them how to manage their bleeding disorder and knowing that they don't have to be a victim. They can take control and they can meet other people that have similar needs and concerns and fears. And really what we're doing, not only building our hemophilia team by all being at camp together, but we are also building the next community of leaders, because these kids leave, they see each other every year, they come back and they become part of the process. When I look at the changes in the hemophilia community over the years, since I'm on the camp theme, because I'm at camp, I am looking really just when I first started 30 years ago at hemophilia camp, it was, and see, I still catch myself saying hemophilia camp. It's not hemophilia camp anymore. And that's the change that I need to catch up with. It's bleeding disorder camp. So my first camp was all boys with hemophilia, but now we have siblings, we have girls that have von Willebrand's disease. We really have a good representation and the faces of what the bleeding disorder community looks like. So I have to kind of pause and reteach myself to not say hemophilia camp. It's a bleeding disorder camp, and it really is inclusive of all of the patients that we serve. And one of the most exciting things that I found is the number of girls that have come to our camp really grows every year. We're not only looking at girls who have von Willebrand's disease or a bleeding disorder, we're also looking at those girls who carry hemophilia, who may not have a bleeding disorder themselves because their levels are in the normal range, but we're really developing those relationships that we're going to need potentially when they have children with hemophilia. And so I'm really excited because a lot of our boys with hemophilia now they've grown, now they have daughters, and they're very excited to send their daughters to camp when they are of camp age. So what I've also found over the years at camp is just the ability for our staff, our multidisciplinary staff that are in clinic seeing patients at comprehensive visits, but also the nursing team coming together, really feeling like you're a part of something bigger, getting to know each other in addition to getting to know the kids, being exhausted, but laughing until your cheeks hurt, and really leaving camp with a better understanding of your team. And I feel like it's really made us a stronger team. We have, you know, a lot more trust in each other because we've seen each other outside of the office, and we share this mutual passion for our patients.
I have a threefold answer to that. The first is, let your patients and your families teach you as much as they can, because they have lived experiences with bleeding disorders and they know a lot about what affects them, what has helped them, what has seemed to be barriers for them. The second thing I would say is please get involved in the community. There are so many things you can do. You can do school, home visits. You can do advocacy days. You can do camp. There are probably lots of retreats, foundation events, things like those pieces that you can do. Even the zoo walks that are out there, you can try those. They're all an opportunity for you to get involved. And the last thing is look to your nursing network in this community. There are experts around the country who deal with bleeding disorders. Don't be afraid to reach out to them and take the learning and education classes offered to new nurses. And that's where you start your body of networking. I will tell you, the most satisfaction was the depth and breadth of nursing that I was able to do. I'm in a lifespan clinic, so I do pediatrics and adult. So I've been there for the birth of a new child, all the way to palliative care for my patients. You get to do so many things related to nursing care. You can do maternal fetal medicine. You can do geriatric care, pediatrics. You'll be involved in surgeries. And I also love the aspect that there's research components that might be available at your centers. Please consider doing those as well. All of those things helped to shape me to be the nurse that I was able to be in bleeding disorders care.
Hello, my name is Carla Watkinson from the University of Iowa Hemophilia Center. I'd like to share a few pearls of wisdom that I've learned in my 33 years of working within the bleeding disorder community. First of all, I think you should meet and develop a rapport with all of your patients and families. You and your team will become their experts. Answer their questions and help guide them through their life as they learn to live with the bleeding disorder. Always remind and encourage them that they are going to be an expert themselves someday, and that we will continue to educate and guide them along the way. Learn to adapt to change and be able to multitask. The bleeding disorder community has seen an ever-growing list of changes over my time that I've been here. Things such as changes in treatment products, changes in recommendations, funding, facilities, facility management, providers, and team members. Interruptions happen frequently, and usually you'll leave work always having a to-do list. Learn to be okay with letting that list grow faster than you can cross up items off of it. Always prioritize. Attend as many educational meetings as possible and meet the bleeding disorder nurse coordinators around the country. These nurses are available to answer questions, provide helpful information, so you don't never have to reinvent the wheel, and utilize their knowledge, tools, and expertise along the way. If you don't have an experienced coworker to guide and educate you in your new role as a bleeding disorder community, reach out, shadow other treatment centers if possible. That's how you're going to learn and build a good team flow at your own center. Don't take conflicts and differences in opinions, personally. Ask questions and ask for explanations so you understand the other person's perspective. Don't be afraid, because you are going to be an advocate for your patient now and throughout your career. So memories I experienced through the HIV crisis. In my first years as a nurse, I worked in an inpatient unit caring for school-age and adolescent children with a variety of different disease processes. In 1985, I happened to take care of my two first bleeding disorder patients with HIV and/or AIDS. At that time, there was still so much that was unknown of HIV. We didn't know, how it was even going to be transmitted, or we didn't have very good knowledge about that. There wasn't hospital policies at that time. And I remember some of the people were a little nervous about caring for those children. And I just went in there and told them, you know what? You guys are not any different than any of our other patients, and I'm going to care for you just like I did anyone. Well, since that time, those poor families, they were scared. They were being ostracized from their, family and friends and their communities. And so they needed that support. In 1990, when I began my career here in the hemophilia and bleeding disorder community, I started working with those patients and families even more. I developed a much stronger relationship with them. And oftentimes we were the only ones they could talk to. So we became their support person as well as their healthcare provider. We spent endless hours in clinic with them, visiting them on the floor, monitoring their care, and then seeking resources on the outside for them as well. Those bonds were very tight. When we lost one, it was like losing a member of your own family. It was very difficult at times, as you can imagine. Unfortunately, it was also a very scary time for them and very challenging for them to tell maybe a partner that they've been having intercourse with that they were infected. Well, sometimes the patient couldn't do it themselves. They needed us to be there to hold their hand and help tell their partner the news that they may be exposed as well. Sometimes they were lucky and they didn't have any exposures to other people. They didn't affect other people, but other times we may have had children, we may have had spouses or other people that now were infected as well with HIV. And so they were dealing with that. Sometimes it led to very tough decisions in our life as a healthcare provider, because you had some people that were very angry, they were very scared, they didn't want to tell others about their HIV or AIDS because they were going to be ostracized again. And they were afraid that that loved one might leave them. So sometimes we had really difficult choices, and we had to demand or almost, have to turn them into health professionals if we didn't make contact with that individual. Sometimes there was a lot of anger and tears, but we made it through. Sometimes it decreased their trust in us. So we had to work through that as we continued to take care of them. Thankfully, due to the research that not only the hemophilia community and the infectious disease doctors, HIV is now not a life sentence for these patients. So they are having families, they're not ostracized, they, have friends in the community that support them. And that, alone, and them having a great jobs and able to, I had patients that were telling me, I'm never going to work. But at age 40 and 50, when these new medications are, curing or basically managing and stabilizing their HIV, they went on to school. So that to me is a true blessing for those families.
Well, thinking about the impact of nursing and the future, for me, I would say basically and fundamentally, really, the hemophilia nurse will contribute what they always have. We've always contributed education to the patient, to the family, other medical staff, people in the community, and that is never going to change. We also offer support. Support to the families, patients, the parents is so huge. When they get told their child has a diagnosis of hemophilia, to suddenly have a person standing there saying, I'm going to be your nurse, I'm the person you can turn to, you can call me, that's huge. And that will always be a big part of this. Also, coordinating medical care to other providers, that is not going to change. And staying up to date. Research, new products, as we know, come along all the time. So I think the future looks good for a hemophilia nurse, and I think will continue to be needed. So how did I get into hemophilia care? We have to remember it was the early 80s, so that's 40 years ago. And a lot of the nurses tell the same story, that we really just kind of fell into it. But for me, I was in a large pediatric hospital, but they did not have a comprehensive hemophilia clinic, a hemophilia nurse, or a hemophilia doctor. I was in the outpatient oncology clinic, and of course we did hematology, we did hemophilia patients, but nobody was in charge of them. Nobody supported them or educated them, especially for what they had. It was just kind of hit and miss. They saw different doctors every time, different nurses every time they came in. It must have been very frustrating for the patients. I can't even imagine, and for new parents. And it was frustrating for the staff. And what happened to me is one day, of course, I was a tried and true oncology nurse. Pediatric oncology was my thing. But one day I got very frustrated about a hemophilia patient. And I kind of went back into the back in the staff room, and I just said, somebody has got to be in charge of these patients. They need to be organized. And of course, everybody looked at me and said, okay, you do it. And I thought, well, okay, I'm going to be in charge of them. I'm going to take care of them. It was the best decision I ever made. It honestly changed my life.